Hello, everybody. My name is Lisa Bortolotti, and I'm a professor of philosophy at the University of Birmingham in the UK and at the University of Ferrara in Italy. And today I'm delighted to chair and moderate this webinar on the special occasion of Mental Health Awareness Week on the theme of the kind of stereotypes, often negative stereotypes, that affect people with unusual experiences and beliefs. And in particular, what philosophers sometimes call epistemic injustice. So this idea that sometimes we don't let people contribute their own experiences in their own terms, contribute to share knowledge, and we don't make them feel listened to and believed. So I'm extremely fortunate today that I'm joined by a great panel, and also a very diverse panel. We've got psychiatrists, philosophers, people working in mental health, people with experience of different aspects of the phenomena that we're going to discuss. And I will let them introduce themselves because I think they know better. But how the webinar will work is that we will have brief presentations around 20 minutes. Then we will take 1 or 2 questions straight after each presentation. And then for the remaining of the webinar, there will be discussion, and we will, of course, take your questions and comments. If you want to contribute at any point during the webinar, there is a Q&A box that you may be able to see at the bottom of your screen. Feel free to type your question or comment, and we will get back to you. And while the speakers will present their work, what I'm going to do is also post in the chat some relevant links that you might find interesting if you want to know more about what they are discussing or their experiences or their work. So without further ado, I'm very, very happy to introduce Martino Belvederi Murri, who is a psychiatrist working at the University of Ferrara and has kindly agreed to share his research and his thoughts with us today. Go, Martino.
I am here in the screen. I want to, it's me. I have to thank you, Lisa, for the invitation, and people who will listen. I make my disclaimers in advance. The first, can you see the slides now? Okay, thank you. The first disclaimer is that my English has gone a bit, I don't find a word, so that's a testimonial to it. So it's not the one I used to be. The second is probably that it's a difficult task to talk about delicate topics such as the perspective from an acute inpatient psychiatric ward. This is some some summary of a chapter we wrote together with colleagues on this difficult moment of some people's lives. So when a person is admitted, is hospitalized in our ward and more in general in others, what sort of problems or issues related to epistemic injustice may arise? I really hope and will struggle, despite my English low proficiency, to maintain a respectful and delicate tone the topic deserves, but please advise me if maybe some word may result inappropriate. I really hope it's not like the case. In fact, I work in an acute psychiatric ward, and at 2 o'clock I'm punching in. So what I'm discussing is a real life experience from my side as a psychiatrist, struggling every day to remain aware of the complexities of our work, of the difficulty on the side of the person I'm trying to help. I will refer to the persons as patients. That's the most common word we use in medicine. We are still within medicine and the medical model, but I prefer person. And in this dialectical between the term person and the term patient, I think lies all the complex tasks we face. In general, I wanted to refer to psychotic problems, so problems related in general, broadly speaking, with contact with reality, because that's the most dramatic situation we can encounter sometimes. Sometimes it's an acute word, so we face situations where a problem, an issue, a mental health issue is poses a risk for the safety of a person, of the loved ones, or simply requires some care. Obviously, contact with reality may require a specific webinar itself. It's a huge topic. What does it mean? How can we interpret it? Especially when, if we refer to the phenomenological literature, psychosis may even entail a different, I've written the word abnormal, but I don't like it, different mode of experience, different, not just feeling a symptom, having an isolated experience which is disturbing or causes suffering, but sometimes it entails having a different relationship with the world than it used to be. Sometimes this type of experience may be so unifying, so strong, that we may not realize that the world that is lived by others is much separate from ours. And in those cases, other people may label this unawareness as lack of insight. That's a topic I've been reading about, and it is also very complex and articulated. But when I remember some American movies, when the going gets tough, when there are some problems that need to be solved immediately because there is a threat, then there is less space for reflection, less space for dialogue, and sometimes that leads to a necessity of being hospitalized. That's where we work. So in this interface, where in a way that sometimes is violent, is too strong, to say, to stop, to freeze the situation and help a person recover from these symptoms, but mostly from these experiences of suffering. What the law, so the law prescribes is strongly linked to the capacity of decision. That's worded in different ways in different countries. In England, it is the capacity assessment. In Italy, we have a different law, but the concept is broadly the same. We have to understand if a person, how much and to what extent and in what domains a person is still able to interpret correctly the shared reality, with all the possible difficulties there are, because even when we are not suffering, we may have huge disparities and huge differences in how we interpret a single event. Just think about politics or religion or other affectively charged topics. But in those cases, there is a huge risk of committing epistemic injustice against a person, because thinking that if a person is suffering from a psychotic disorder or is experiencing a psychotic episode, automatically, necessarily is not able to judge any aspect of reality. That is an unnecessary and wrong generalization. Actually, we see all the time that even, for instance, when a person has a persecutory experience, they often are completely able to judge many situations. But the task of the psychiatrist is not to judge, to explicitly put a label of normality, is to help a person not to increase the level of suffering or relieve the risk because of some situations, some disorders. I'm really trying to have a broad language because I believe I'm not speaking just with colleagues who are clinicians, but in general to people who are interested in psychiatry, mental health care. In these cases, so we may encounter some situations, for instance, where insight is in general linked with a lot of factors that have nothing to do with the suffering, with psychiatry, with disorder of symptoms, with culture, with models, with ideas we share with our group. What does it mean to be depressed? What does it mean? What does that word mean? And the only thing I'm really afraid in the world still goes on is stigma, because anywhere we go, stigma is still persisting, and suffering, having suffered from some experience in the area of mental health, even after a century of more modern approaches, still is attached to a pejorative account. And that leads often to people who have the acute episode after maybe recovering to meeting the consequences of identifying with a mental health issue. I remember Italy, Latin countries, and sometimes other countries where there is less literacy on mental health, sometimes struggle with these issues, even when the socioeconomic status may not be low. So it is not necessarily linked only with socioeconomic status. But I remember when the first Prime Minister of Norway declared publicly he suffered from depression. That was, I think, a huge breakout, a huge step forward against stigma. But when we work in this setting, we sort of negotiate. We have limited time, we have limited resources, I'll get back onto that, and we go to negotiate about autonomy, about involvement in healthcare decisions, agency, human rights, and most of all, dignity, the dignity of the person. The difficult balance is on how to use an acute and a strong measure which may deprive a person for a certain amount of time of the liberty to help him or her without worsening self-perception, without worsening the sense of dignity. That is one of the most difficult challenges I have in my work, where we every day try to do that in a really limited amount of time, surrounded by maybe the ER doctor, the police, or loved ones. So we have to triangulate, use the right words, and maintain, for as much as we can, the patient empowerment. So the involvement in decision-making has to be genuine. Even when we think that a situation is extremely dangerous, it requires very, very probably an involuntary admission. Even in those situations, if possible, and for what is possible, we must involve a person in the decisions that regard the modality, the time, and all the aspects that we can accommodate and make possible. So humanity ultimately means humane care, ultimately means respect, and means mutual understanding. I think I'm going a bit slow, so I have about 13 slides, but I'll just try to elaborate on the main points. Testimonial injustice, so is easy, is around the corner. Every time a person is brought by, I don't know, police officers or even the most humane police officers I've worked with, and there is sometimes the idea that this suffering from a mental disorder or from mental health issues automatically leads to unreliability. And if we are here, we know that it's not true, and that we need to zoom in and help person and the loved ones to negotiate this dialogue, so to participate as much as one can. But there is also a sort of paradoxical self-inflicted testimonial injustice, because when a person continuously hears by others that has a problem, one person may generalize and feel more generally unable in other aspects of life. So the empowerment is done by the clinicians, but also nurses, but all the staff, and also patients themselves. We really have to help a person maintain a hope attitude and an empowerment attitude toward oneself. And hermeneutical injustice, we have to remember that some psychotic experiences may be so ineffable that they are difficult to conceptualize, to transmit their sensations, their lived experience, that not necessarily are easy to be put into words, especially in the acute setting. So we have to discount every time we meet a person who's suffering that in that moment he or she may not be able to explain what is experiencing. Take the example of catatonia. I've had many people who've suffered from catatonia after months explaining to me what they were feeling in those moments, like intense anxiety, paralyzing thoughts, and so on. So we cannot, we have to learn to live with uncertainty, with a certain degree of uncertainty, and know that sometimes answer will not come or will arrive later. And for the person who's being cared, it's very frustrating not be able to communicate what they are going through. So I think these are two topics strictly related to epistemic injustice in that particular situation, especially because it's dramatic. And I won't go into details on the controversial issues of coercion, because clearly there is no one that believes that coercion is not something that is extreme and dangerous and potentially traumatic. We have data on that now. It's something that is given and understood. But one of the most difficult topics is the decision to enforce some sort of coercion to protect a person and to reduce risk, so exclusively for safety reasons. The issue here is not to find that balance, which is, especially in the UK, it's a dialogue with the judge, with external figures. In Italy, it's more on the shoulders of the psychiatrist. All around the world, these procedures change. But the issue remains, that is to take responsibility to help a person against his or her will. And that's the most dramatic situation a person, a client, a patient can, and a psychiatrist can find, and all of the other stuff, of course. So it entails also sometimes informal coercion, so more subtle forms of coercion, which are not less humiliating or problematic. That coercive practices sometimes, but I say maybe in a minority of cases, are lived not with just humiliation or trauma, but sometimes some studies suggest that they may be lived as protective measures, or at least with a certain degree of ambivalence. So a person can feel at the same time humiliated, forced, imprisoned, but at the same time, in a way, protected. And sometimes people would recognize this in hindsight. So after a while, they say it was necessary at the time. That's a relief because it opens a path of healing, of adjusting the relations between the staff and the word and the person, and build a constructive and helpful narrative, not just facts, but also a narrative that person can internalize and remember. So, but that's an optimistic case scenario. Sometimes, unfortunately, things can lead to humiliation, dehumanization, or powerlessness. And there is a double hit, which leads to demoralization. So chronic loss of hope, identification with a powerless role, which is not, obviously, that is not desirable, and is something we have to work against very strongly. Let me just, maybe I'm about at the end of my time, but let me just underline this, because it's the presentation of paradoxes. It may appear paradoxical, but what can be done to at least limit the harm, explain, speak, inform, exchange ideas? I really love the British expression, let's agree to disagree. When I was in London 10 years ago, I first heard it and I really loved it. I say it in English to people I help to. What does it mean, actually? It means let's find a common ground where we do not agree, to build on the rest, to build respect, basic respect, and pinpoint the level of fracture, but in a certain type of dialectic. And dignity is not fixed, it's not something that is given, it's not something that is fixed, that is not merely due to pragmatic aspects, but it builds upon that. So we have to work on that every day, on communication, on agency. So the ethical distress that may derive is not only for people we help, but also for psychiatrists. Obviously, it's nothing compared, because the entity and trauma that can be derived from these situations is completely different. But it can lead to burnout, and burnout can lead to cynicism. And that's not something, no one would want a cynical psychiatrist or a person that helps you who has given up on hope. So the shift is to the least coercive care possible. That's the principle that is highlighted in guidelines. And it is the way we adopt and translate it into reality that matters. And also everyone would need to have studied trauma-informed care, all the little details and principles, but also some involvement like the crisis cards, the advanced directives. So people who unfortunately underwent a crisis will have to think about the future. If the crisis happens again, let's discuss and plan what we can do to make the intervention less harmful and more beneficial. And in general, I think there is a huge need, and Lisa said the book was downloaded by many, many people already, and that's because it responds to a moral need, a moral issue that being too technical swipes it under the rug. We have to bring forth the moral issues, discuss them openly and constructively, and there is really, I think, a big imperative to do so, especially in an era where the landscape is changing so fast and new instruments are available, so we should use them. And the last paradox, I promise, is the paradox of this increasing attention to ethical and philosophical issues, but reduced resources. I know that it may sound a complaint said by a psychiatrist, but it is so actually. To work better, you need better resources. That's something no one would dare to discuss in other fields, like I don't know, in constructions, you need better, stronger walls to make better houses. Here in mental health care, I don't know why, when we improve the level of aims, the resources are going down. Especially, I know I'm speaking for Italy. We have been the pioneer of institutionalization. That was hard to say. We closed asylums as the first country in the world, but we are the nation that spends less in mental health care. That's the paradox. So it's closing asylums, it was necessary, it was an imperative, but it didn't mean just to save money. It should mean to improve care. That's a different aim. And so it said in better words, the evolution of principles must be matched by evolution in resources, in times and spaces to do our job better. Otherwise, it remains an empty word, or all is left to the volunteering goodwill of people who work in this field. And that's not right, and that's not right for people, especially who are helped. Thank you.
Thank you. Thank you very much, Martino. That was brilliant. You can stop sharing your screen now. And we're going to take just one question right now before we listen from Fiona. And we've got a question from Tom, who says that, first he says you made some great points. And then he wonders if you could share any thoughts on advantages and disadvantages of psychiatrists having powers to impose treatments on people, both in acute presentations and for prophylactic purposes.
That will require another presentation, obviously not. Thank you, Tom, for the question. I think I'm citing Spider-Man. Great powers and great responsibility. So the more we see a power, the more we are already starting on the wrong foot, because it's a responsibility. So when we conceive it as a responsibility, that the weight of these important decisions must come. We need to gather all the information we can. We need to establish a relationship. That's one thing that can lead to advantages for a person. Obviously, we cannot avoid to be biased to a certain extent, but any psychiatrist who's done some work on him or herself should be aware of this bias risk we have in thinking about the good for a person. This is the paternalistic view, which is, according to the modern philosophy of medicine, is wrong. But I challenge anyone who works in medicine or who cares for other people who are temporarily incapacitated. In that moment, we need to take the reins and help a person not to be harmed. So as one is unconscious and the ambulance comes, in that moment, you cannot avoid to have your responsibility. So the best you can do is to do as much as good as you can for the person. It is sort of an endless debate, but only care, time, resources, and good training, I think, are the ingredients to work on that side.
Great, thank you very much, Martino. That was brilliant. If there are any more questions for you, feel free to type answers in the box. But we need to move on with our webinar, and we are extremely happy to have Fiona next, who can introduce themselves and also tell us more about their work. Thank you, Fiona, for joining us.
Thanks, Lisa, and thanks, Martino, for that really good talk. I feel like we could talk about this stuff all day. So I'll just start sharing my screen because I have prepared some slides just to hopefully keep me on track a little bit so that I don't go off on too many tangents. So let me just get the slides up. Hopefully people can see that okay. Great. So yeah, Hi everyone, I'm here to talk about about the work I do at Voice Collective, which is based at mine in Camden, but also about the collaboration with Lisa Bortolotti through the EPIC project, and really thinking about agency and epistemic injustice as it relates to young people who hear voices or have other sensory experiences or kind of unusual perceptions or beliefs. Just to give you a bit of a kind of background on who I am and kind of the work we do. So Voice Collective is a project that's based at Mind in Camden. It does work across London and the UK more broadly, but we also have international reach where we've ended up collaborating with people across the world and speaking at conferences and other events as well, globally. The bulk of our work on Voice Collective is that we support people under the age of 26, so young adults and young people, and their families, carers and supporters, with a real emphasis on young people who have highly stigmatized and kind of potentially quite overwhelming and distressing experiences that can be hearing voices, it can be seeing things, it can be tasting things, smelling things, having felt presences, multiple senses of self, forms of dissociation, paranoia, the list goes on. But essentially, we are established to provide kind of more community grassroots care, so kind of coming from a non-clinical, non-pathologizing community perspective to offer support. Voice Collective also sits alongside Voices Unlocked, which looks to do similar work in prisons, forensic hospitals and immigration removal centres, so supporting people who have these experiences there, as well as the London Hearing Voices Network, which essentially offers training as well as support to people who want to set up peer support groups for adults who hear voices across London. But Voice Collective itself is currently funded by the City Bridge Foundation, so we're very grateful for the funding to continue the cool work that we do.
Yes.
I also thought it might be useful to share a little bit about kind of what the work that we actually do at Voice Collective looks like and kind of what form that takes. So just to kind of touch on how we do one-to-one support with the young people, but also with their parents, families, carers, and other supporters. So really trying to kind of have a holistic approach to understanding that it's not just the individual that's affected by these things, but everyone around them is too, and wanting to support that. And recognizing that those people are going to be there for that person when, you know, in times that we as a team can't. So really trying to kind of provide as much wraparound support as we can. We also kind of help facilitate, but we also establish peer support groups for young people who have these experiences. So we have one group for 11 to 15-year-olds, which is aimed at kind of a slightly younger age group. And with that, you know, we often hold them online. And so we'll have like all kinds of conversations using lots of emojis or memes and things to communicate. And obviously working with young people, all sorts of interesting choices for emojis come up, but we actually were able to use that to quite powerfully think together about what emojis would we use to describe how our voices make us feel, or kind of, you know, would we give particular voices like a particular emoji that represents them. But we also have a peer support group for an older age group, so 16 to 25-year-olds, where that's more of a kind of traditional kind of sitting as a group online, kind of chatting to each other, asking each other questions, and just kind of providing solidarity and kind of friendship to each other. And we also offer peer support groups to parents as well. We have an online Discord server, which we created with the young people and was built in response to them thinking that that would be a good thing to have. So that's essentially an online forum where young people who hear voices or have other highly stigmatized experiences can kind of come together essentially from across the world and kind of just be there for each other outside of groups and kind of just in another setting. We also do things in terms of setting up young people to be on advisory groups for research projects or steering groups for service development, because a big part of our approach is actually really trying to help young people kind of be heard and be listened to and have input into things. So really trying to push back against the kind of epistemic injustice that they face by actually kind of trying to show the value knowledge that young people do have. and trying to really create spaces where that's welcomed and really kind of worked on. We do creative workshops because, touching on kind of something Martino mentioned in his talk, ineffability and kind of having experiences that there just aren't words for can come up quite a lot. And so having other forms of expressing ourselves, or just being able to kind of have spaces where we can kind of do something else. And so then even if we don't have words to describe what's going on, we still have kind of creative activities to kind of engage in and be alongside each other. Sometimes that can be one of the most healing things. We also run training courses on kind of understanding and supporting young people with these experiences. And we have resources where we have leaflets, booklets, our website, and other things we've done as well. So we end up doing quite a lot of Voice Collective for kind of a small little charity project. But over the years, you know, there have been things that have come up as kind of recurring issues. And so when I saw Lisa's work on kind of epistemic injustice and the kind of lack of agency that young people had in encounters with clinicians, that's when I was kind of like, we could really kind of get on board with some of this stuff. And because, yeah, for the young people we work with, you know, young people are often seen as incapable. There's often an emphasis on young people, particularly who hear voices, kind of to kind of be quite powerless, but the role being on kind of staff and people in power to kind of actually create those situations for young people to be empowered, rather than necessarily the young people being able to kind of step into power and kind of have a bit more ownership over it. Their experiences were often framed as a deficit and kind of part of an issue, which, although yes, for some people their voices can be massively distressing and overwhelming, there are times where sometimes there may be kind of trying to be helpful in an unhelpful way, or that maybe some people do have very positive experiences of their voices, or actually quite neutral ones too. So it kind of was quite difficult for young people who had these more kind of, less stereotyped versions of voices to kind of talk about them, for fear of it being seen as just something kind of inherently wrong and an issue with them and how they experience the world. It also kind of often tends to privilege the role of kind of the professionals and the kind of mental health services that exist, rather than kind of privileging the role of kind of communities and peers and the person themselves. And it often locates a lot of this stuff within the individual, rather than kind of looking at broader, more systemic factors. And so, we come across a lot this kind of idea that there's a kind of prevalence of the kind of, yes, there's a psychosocial element to understanding these experiences that's kind of become, more in the sphere of understanding in recent years, but there's still a massive emphasis on kind of illness models of understanding voice hearing, and that the kind of inherent way to navigate that is with medication, which again is kind of a massive contentious area within the mental health field. We've also seen a real kind of colonization of survivor movements and the co-option of grassroots approaches. So we've seen kind of peer support be kind of adapted and adopted into more statutory settings, but in the process of doing so, becoming something that's a bit different to what it is when it first started out as a more form of resistance and that kind of community support. And also, again, like Martino touched on earlier, about kind of how sometimes mental health services and the way they operate, and if kind of staff are burnt out or kind of aren't, practicing those kind of ethical values of kind of respecting people and having a humane approach, then it can be a very oppressive system to be part of, where particularly young people often experience a lot of coercion into kind of going along with whatever kind of treatment pathway is recommended to them. And so we would often have young people coming to us with all these things going on and really struggling with it. And often people's struggles with kind of how they were treated because of their voices or other unusual experiences was the issue, and less than the voices themselves. So that became something quite curious to us. And for us at Voice Collective, in terms of kind of, I guess, our approach, we are a big fan of kind of pluralism, where we very much want to work in a way where we support people to find an understanding for their experience that makes the most sense to them, and come up with kind of ways forward and ways of managing life in accordance to that. So we support people where their understandings of their voices or their visions or their felt presences are part of like a spiritual transcendence or emergence. And, you know, there's a whole spiritual emergence network of people who have really, again, connected over that shared experience and kind of wanting to create solidarity around that. But we also know that these things can be related to kind of parts of people's sleep cycles and sleep patterns, and around fever and infection, in relation to trauma, in according to kind of psychic connections and gifts and abilities, both prescribed as well as kind of non-prescribed drugs, things around bullying, physical illness, biochemical imbalances, bereavement, side effects of certain things, and also potentially just seeing it as an individual difference or a form of neurodiversity. These are all kind of explanations that emerge once we give people space to kind of think more broadly about kind of what does this experience of hearing voices or whatever else it might be mean for them. But actually, you know, if anything outside of seeing it as a mental health issue is kind of held too strongly by an individual, that belief then in itself becomes pathologized. And I always find it very interesting on some of the trainings I do with professionals, where I'll kind of have a scale of 0 to 100 and have a bunch of kind of different prompts, where one will be, for example, aliens, one will be about kind of being able to predict the future, one will be about kind of psychic connections. And so kind of some elements that come up on here, but also some elements that might come up in what would usually be considered unusual beliefs, like ghosts and spirits and the existence of those. And people would have to kind of anonymously mark where 0 is kind of believe that it's not a thing at all, it doesn't exist, doesn't happen, 100 being completely believe in it, it's absolutely a thing for them, and 50 like sort of in the middle, being like they don't know if it's a thing or not. And we would see a real distribution and scale of some people who really strongly believed in aliens and the possibility that they exist or that ghosts exist, and other people who are more skeptical. But actually, like, it was really interesting to see that beliefs around those things were very present within staff teams in these kind of mental health settings. And so then it brings up the question that maybe it's people's relationships to their beliefs about things that's kind of more of the issue. And about that kind of, again, what Martino was saying about being able to sit with kind of maybe, yeah, that we don't know certain things. And so if people do have particularly strong beliefs, even if they're not shared, then maybe it's more about the relationship. And so through Voice Collective, we also get to do things like exploring some of these tensions and kind of coming up with ways to explore them in different ways. And one of the joys of working with young people is to get to do things like memes. And so holding meme making workshops where we get to think about kind of systemic issues that affect them, but also these kind of ideas around kind of epistemic injustice and sense of agency in relation to how they're treated by mental health services. And, you know, the fact that for a lot of young people, understandings around complex PTSD just didn't tend to be there. And so then they would be labeled as kind of psychotic as a result, and they wouldn't really receive the help and care they wanted around their more trauma-based understandings, for example. So yeah, if anyone's interested in seeing more of the memes that we made together, then let me know and I can put the link in the chat later. But I think it just has a way of kind of being able to convey some quite complex kind of issues that come up for people in a way that just feels very accessible. And I guess at Voice Collective, this all plays into how in the work that we do and our whole approach, it's all about kind of really trying to genuinely and authentically listen to people wherever they're at and kind of whatever they're coming with, and that kind of, I guess, person-centered, individualized kind of response to people, because we're kind of aware that people can really become quite invisible when their views are sought by proxy of those in positions of power, and that young people often really struggle to be heard. They're used to being told what to do. They have all these forces kind of acting on them, their parents, their schools, mental health services, if they're part of those, kind of peer pressure. They have a lot of forces kind of, you know, telling them what to think or kind of what to say. And so we really try to create spaces where they're more able to find themselves and what they want to think and say about things. But it just felt really important to think about with Lisa and the EPIC project about, you know, it's one thing to be a young person who kind of struggles to be, you know, your knowledge to be accepted anyway and to be valued. But actually, if you don't occupy consensus reality, then kind of epistemically speaking, you're also inherently on the back foot, because you are then seen as kind of the most unreliable narrator there is, essentially, because you don't occupy the same reality. Although I think there's an argument to be made about how, you know, everyone experiences the world in their own way through their own kind of worldview and personal experiences, things like that. But yeah, I think when you kind of have experiences that a lot of people struggle to understand and comprehend and are maybe quite afraid of, then it's very easy to feel like your input is then written off and framed as a lack of insight, or kind of framed as just kind of lesser than other forms of knowledge, such as kind of medical knowledge. And so I like to include this just as a slide where we actually created a special interest research group with Sarah Parry at Manchester University, where we held a workshop that was all about asking what people found helpful or unhelpful in terms of talking about their sensory experiences with clinicians. And for me, this is always just kind of, every time I look at it, it almost gives me goosebumps, because for me, this is a prime example of the wisdom and actually the epistemic power that comes with young people, particularly who have these experiences. And I think, yeah, to kind of have this depicted in this graphic is always a really nice thing to be able to take to conferences and that kind of thing. So yeah, this is another example of kind of what can happen when we create these spaces for people to kind of be asked their thoughts and for them to be valued in what they have to say about things, and for kind of what can happen if we begin to actually, you know, really create space and a platform for these views to be kind of put out there to those who occupy more powerful positions, perhaps. And so another example, which we'll come to in a minute, is that we worked closely with Lisa to develop an animation around people's experiences of being voice hearers and people with unusual experiences, and we managed to kind of take that into all these metaphors of animals. So I won't spoil it by kind of sharing too much details. I'll just kind of stop sharing, and maybe Lisa, you could play the video.
Yes, great. Thank you so much, Fiona. So why don't I try and play the video, and then we've got a few questions for you, Fiona, we can take straight away after the video.
Sounds good.
Whether it works. Fiona, can you see my screen?
Mm-hmm.
Yeah, perfect. Okay, so.
The wolf, the snake, and the butterfly. Challenging assumptions about young people who hear voices.
Wolf, what are you doing here? Hasn't your pack moved on last night?
They left at sunset, without me. With my limp, they think I'll be a burden.
Butterfly, what are you doing in the clearing? Isn't the poppy field more your scene?
Well, I'm tired of the teasing. Bee keeps saying that I don't pull my weight.
What nonsense. Without your constant wandering, there would be hardly any flowers.
Sure, I'm a good pollinator now, but Bee thought I was useless as a caterpillar, eating all day long, and still thinks so.
Stereotypes are hard to overcome. I'm really gentle, but humans run scared when they see me and even beat me with a stick if they get a chance.
Snakes and wolves win no popularity contest. Aren't we always the villains in fairy tales?
Young people who hear voices have similar experiences to ours.
We're often isolated because we're different.
We're considered dangerous even by those who are there to support us.
we are treated as if we can't achieve anything.
When others find us useless or dangerous or exclude us because we're different, we experience harm, and it's harder for us to do the things that we value.
But we do have a lot to offer.
And here it is, our video. I hope you liked it, and I hope it speaks to some of the issues that Fiona and Martino have addressed in their talks. And probably we can talk a little bit more about the video later, but let's get some questions for you, Fiona. I see that there are quite a few coming in. So Tom is asking whether you could share any thoughts on the extent to which epistemic injustice occurs in mental health settings. So if society considers that patient realities when they're psychotic are not valid, might it also describe the patient experience as something like epistemic bad luck rather than necessarily an injustice?
That's an interesting question, and the kind of idea of epistemic bad luck, like there's something to be said for that, I think, but I also think within the realm of kind of mental health and the Hearing Voices movement, there has been harm to the extent where, it's a field of medicine where there's a whole survivor movement against it. And to me, that speaks to the harms that do occur to people, both in either their kind of knowledge not being respected or validated, but also the kind of prioritizing and hierarching powerful kind of narratives above their own. And I think we also see this quite a lot within kind of, the people often being given like multiple different diagnoses, when quite often they will be telling a narrative of their experience about, like, for example, the one I spoke about where there are people who very much, for them, their experiences are rooted in trauma, but they were kind of diagnosed as psychotic or schizophrenic and kind of put on a treatment pathway for that. And it wasn't until many years later, after so long of them kind of like trying to explain to people about, their understandings of where their experiences were coming from, that kind of things were then changed and then things improved for them. And I just also feel like epistemic injustice, it's within mental health services, it's not just limited to people who kind of don't occupy consensus reality and who kind of have experiences outside of that. I think it kind of transcends many different kind of diagnoses and different experiences that people have, and the kind of particularly the more inpatient system can be a lot more likely to kind of be a place where kind of harms occur. So yeah, I'm sorry I don't have kind of too in-depth an answer on that, but that's kind of my take on it. I don't know if you have any thoughts, Lisa.
Yeah, I think maybe the video goes somewhere towards answering Tom's question as well, because as Fiona mentioned, the video was something that we did together with some of the young people at Voice Collective. So we met over a number of evenings discussing what we found in previous projects, talking to young people who had accessed emergency services in the UK, and also discussing the lived experience of the young people who were talking to us and seeing whether there were any commonalities or any differences. And it seems to me that given the kind of conversations that we had, it wasn't just an accident that these kind of stereotypes were affecting the behavior of people around the voice here, are not just the health professionals, but the teachers, the parents, the friends. We could see some patterns. And I think when you see the patterns, you tend to think, okay, so that's not just bad luck, right? So maybe something more than that. Maybe there are some actual stereotypes that seem to be triggered in our understanding by the behavior of people who hear voices, who have unusual beliefs. And that's what we started doing, started thinking whether, there were some categories of stereotypes that were more common than others. And of course, it's not exhaustive, We could have gone on forever, I think. I enjoyed the experience so much, talking to the young people and thinking more reflectively about their experiences were like. But we found these 3 clusters that we thought was worth talking about. So first of all, this idea that the moment in which you don't have an understanding of reality that is shared by other people around you, you become less useful. You become like a free rider. You become someone who can't do things, or can't contribute to kind of the common good or the community. And that's why we thought, actually the young people thought, that the example of the caterpillar and the butterfly was really good, because of course, also the caterpillar is extremely useful in the ecosystem, but we might end up thinking of the caterpillar as someone who just keeps gobbling up stuff and eating and doesn't actually do much for the garden. Whereas it's quite obvious that the butterfly is a pollinator. So we might, be thinking that, okay, maybe the caterpillar is not such a team player as the butterfly. But, the moment that you are thought to be, someone who can't contribute or someone who is not useful, it's very difficult to change people's minds. So even if, you change as a person, you develop, you overcome your difficulties, people tend to see you still with the same eyes as before. And I think this was inspired by experiences of the young people with medical records and medical notes. So the fact that every new healthcare professional was seeing them, was reading about their medical history, and was making assumptions on the basis of those notes, even if maybe the person in front of them was 3 years older and a completely different kind of experiences or very different situation anyway. So we thought that was an interesting cluster of stereotypes. The other one was dangerousness. And I think dangerousness is so interesting because it's quite specific to unusual beliefs and unusual experiences. We may see other kind of mental health issues as problematic, but this idea that people are unpredictable, that they could do anything, right? We tend to associate with these kind of unusual experiences and beliefs. And sometimes there is absolutely no justification for these assumptions of dangerousness. And again, one of the young people had this brilliant idea of the snake, because most snakes in the UK are actually not venomous, not particularly dangerous. They would never attack a human being unprovoked. And yet we tend to think of the snake as the symbol of evil, as something to be avoided. Very in the popular culture, the villain is always associated with a snake. Like they were thinking about Voldemort, weren't they, Fiona? So we thought that was really interesting, this assumption that someone is going to be unstable just because, they've got unusual experiences seems to be very damaging for young people and for the relationship that they have with those around them. And finally, the last cluster is about exclusion. So we, again, it was the young people idea, but this idea of the lone wolf, the wolf that is excluded by the group. And Fiona remarked to me that it was such a good example because actually wolves love the society of their conspecifics. They live in groups. That's what their form of life is. And being excluded by the herd, not being recognized, being left behind, is extremely painful to social animals like wolves. And that was such a nice example of thinking that, okay, because someone is different from me, someone has experiences that I do not share, I'm not going to include them. So in the video, we had this idea of the children playing in the playground, but you can apply to all sorts of situations where people are just maybe even unthinkingly excluded by things just because things present themselves differently to them, or they have, they express their views in a different way. So yeah, we focused on those 3 clusters because we thought, there are patterns here. And it's unlikely that it's just, bad luck because it happens to so many people in so many different circumstances. Maybe there is something there that deserves to be further explored. Of course, this is just the first step. We want, more science on this, more because on the basis of more data, we can then kind of justify taking action and do something about it. I don't know, Fiona, whether you've got anything to add on the video in particular.
I think that's a wonderful summary of the video and the conversations that we had in the run up to it, and kind of the the things that were coming up for the young people that they wanted represented, like they were definitely the kind of more prominent kind of harms that they'd experienced that they wanted depicted in this video. Obviously, there was plenty of choice, and again, with kind of other young people that we support, we see kind of, you know, harm come in lots of different other ways too. But for sure, in terms of the video and the young people we spoke to for this particular project, so that's kind of the key themes that you've kind of spoken about really wonderfully. So I don't think I need to add anything. But I agree, this notion that kind of when you either look at kind of the kind of history of psychiatry, and particularly of the Hearing Voices movement, which is kind of a global movement, right? Like, it's international. There are countries, several countries all across the world, who all have established their own Hearing Voices movement, who are trying to bring kind of these more humane and rights-based approaches to working with people who have these experiences, and to kind of try and focus on not being scared of people who have these experiences, and actually being curious about it, and thinking about how interesting it can be, and kind of the kind of sometimes social or life commentary that these experiences have for people, and also tackling things around kind of recognizing that the kind of social isolation, and the kind of just being on the margins of society for lots of intersecting reasons, right? There are different other forms of marginalization and oppression that lead to people being kind of outed and kind of put on the outskirts, but kind of, again, these unusual experiences being one of those factors. There's just kind of so many stories of harm within the mental health system and within people who have these experiences, that for it to kind of just be bad luck, it kind of feels like that would be, like you said, Lisa, like happening too often to be a coincidence.
Yeah, and in a way, it's part of the point of Project EPIC, to try and get some more data about these kind of experiences, so we can make generalizations in a way that, you know, it's a little bit more confident. And so the idea of EPIC is really to study whether the phenomenon of epistemic injustice applies in different healthcare contexts. And a lot of it has to do with mental health. So we have a group working on dementia patients. We have a group working on people who have maybe a diagnosis of a serious somatic illness and mental health issues, so in psycho-oncology. And of course, we've got people working on young people with unusual experiences and beliefs. And it is so interesting. We are very early days in our case studies and our kind of data collection, but already we can spot a lot of differences. So there are negative stereotypes associated with this diagnosis, but they're not always the same negative stereotype, and they affect people differently also because they are, of course, the different stages of their life, and so they have different needs. But yes, hopefully we will be able to share more results soon. So Georgina has very patiently waited a long time for her question to be read. So Georgina is working on aphantasia, and she was wondering whether we think that there are similar issues with regards to stigma and stereotypes that apply to different conditions. So maybe conditions that are not necessarily distressing, but are definitely unusual. So people might not maybe have good mental health literacy and know exactly what is happening to people. And so whether we are considering, or will be open to considering applying the language of epistemic injustice, this kind of framework, more broadly to other cognitive differences. I think, Fiona, you started talking a little bit about this. Do you have any more thoughts?
I think for me, like, it's not an area I'm an expert in by any means. However, I do think that there is something to be said about, there are cognitive difference kind of frameworks for understanding voice hearing, even in terms of like auditory processing stuff and, other things going on there. So I suppose it's kind of how that is utilized with people who have those experiences, and kind of how it's kind of, whether it's imposed or whether it's kind of something that's kind of introduced as a kind of possibility for them to consider and think about if it applies to them. Like, the power difference with these things makes a big difference, I think. But I definitely think that when we were talking about, people can be kind of marginalized and kind of, epistemically on the back foot, so to speak, for a whole host of reasons. And I think to explore that in relation to kind of cognitive differences can be really interesting. So yeah, that's kind of my take.
Thank you so much, Fiona. We've got a question specifically on hearing voices, so this one is for you. What impacts the day-to-day life of people who hear voices the most, would you say, from your own experience with the Voice Collective and so on?
I mean, that's a big question, and I wouldn't want to kind of like generalize an answer to so many people where it's such an individual thing. I mean, I can say, you know, from my own experience as someone who hears voices myself, it can really impact on kind of, I've kind of come a long way with my experiences, but kind of back when I was a teenager, I was in a psychiatric unit for a year, trying to make sense of these experiences, and had an experience of where it was taken by mental health professionals in a very concrete way, whereas my experience of hearing voices is actually a bit more kind of fluid and less kind of stereotypical. So it kind of got taken, I suppose I use that terminology as kind of an approximation, but it also felt like it fit in a certain way. But it got taken in a very concrete way by the professionals, and I was then medicated very strongly and had lots of side effects from the medications, without too much space to really question, like, what are you meaning by hearing voices, and what sense do you make of them, and kind of, you know, there wasn't much room for that at all. And I think there are some mental health services that have progressed a lot in terms of how they approach voice hearing, but yeah, kind of for a lot of people, the response of society, but also mental health services can be problematic. Some people, it makes it really hard to leave the house. For some people, it's kind of linked to their trauma and can trigger flashbacks. Some people have kind of really bullying voices that kind of voices that tell them to take their own life, and kind of feel like they have a lot of power over them, and can kind of evoke a lot of fear and a lot of very powerful feelings. But I'm also aware that, you know, some people have voices that make them laugh and are really funny, and have voices that kind of nurture them or guide them. So I think, you know, we can't really give any sort of generalizations to the impact on voices in people's lives, because it's so individual. But I would highly recommend kind of checking out the Hearing Voices movement and the videos and stories of everyone who's kind of part of that. I know that Eleanor Longden did a TED talk, which is kind of one of the most popular TED talks in history, I believe, and talks kind of really really eloquently about her experience of kind of hearing voices and how she made sense of them, but also the reactions of people around her. There's also people like Jackie Dillon, Ray Waddingham, like a whole range of amazing people who are kind of talking about their experiences. And there's also a book called 50 Stories of Recovery, which is kind of 50 stories of people talking about their journeys of voice hearing and kind of getting to a point of living a life they want, and that kind of thing. So if you're wanting to kind of really dive into the diversity of what living with voices can be like, then I'd say those are some solid starting points.
Thank you so much, Fiona. Those are brilliant suggestions. I'll try to put together the links and share them as well with the participants of the webinar. One thing I wanted to pick up on before we close, I noticed that both in Martino's presentation and in yours, the idea of empowering young people was very crucial, was very central to your messages. And you have also given us some very concrete examples of how Mind in Camden and the Voice Collective attempts to empower young people in different contexts with different activities. Do you have any recommendation for like parents or friends or even healthcare professionals, given that, you know, you provide training to them as well, about how they could try and empower young people in these difficult circumstances? I mean, are there things that we can do when we talk to young people that can help them, even if, you know, it doesn't solve the problem, but makes them feel less alone and more supported?
Yeah, absolutely. I mean, again, I deliver whole trainings about this, so to kind of condense it into a tiny thing is very, very difficult. But there's yeah, some work that's been done around kind of like stories of recovery and what people have found kind of really helpful in that respect. And it basically kind of got narrowed down into 4 key themes, where one was kind of listening to people, like I'm really listening to them, so hearing them in what they say, and believing them actually. So the second one was believing people in what they're saying and not trying to contradict them, not kind of invalidating them, but actually kind of believing what they're saying and kind of where they're at and what's happening in their world. The fourth one was being an empathic witness to their suffering. So kind of having real empathy and being able to not necessarily try to jump in and fix things and problem solve and offer solutions or coping strategies straight away, but to actually kind of just meet the person where they're at. And I think sometimes, you know, when people are very overwhelmed and distressed, there's a real kind of human instinct to want to make it better for them, right? And to kind of tell them that there's a light at the end of the tunnel, so to speak. But we never, that's kind of an example of imposing hope. And the last factor was holding hope for people. So it's not about imposing hope. So it's not about telling them there's a light at the end of the tunnel. It's more about kind of just helping them navigate the darkness of the tunnel they're in. And if you can see the light at the end of the tunnel, that's great. You can see that and hold on to that. But it's about recognizing that if they can't see it, that's okay. And they might end up turning in the other direction and finding their own light anyway. So it's more about just being alongside them in the tunnel that they're in, and kind of maybe just being alongside them and helping them find their way around in the dark until they are at a point where they can see some sort of light for themselves. And so that's kind of the 4 tenets that underpin a lot of kind of how we work. And I feel like none of them are things that you need a PhD to do. They're all kind of things that everyone is capable of. That's not to say they're easy, because being an empathic witness to someone suffering is not an easy thing to do, to kind of be with someone in their pain and to kind of acknowledge and validate that pain and kind of sit alongside that. That's not an easy thing for us to do, but that's what makes it all the more important. I'd say, like, yeah, those are the kind of key underpinnings of our practice and how we try to approach things in supporting people who are distressed. But also, if anyone does want to know more about this stuff, then you'd be very welcome to book a place on one of our trainings and find out more, or just to drop me an email and get in touch. Very happy to talk about this stuff all day.
Thank you so much, Fiona. This is so helpful and informative and really, really appropriate for this Mental Health Awareness Week as well. Like, everybody wants to know a little bit more about what they can do. Before we close, and again, I put some links in the chat also to the TED Talk that Fiona was mentioning. I just want to remind you that the paper that we wrote together with Fiona and the young people from the Voice Collective on the stereotypes associated with hearing voices is available open access in the same volume where Martino's paper on the challenges of an acute word is also published. So this is the book, and you don't need to buy it because it's actually available online, open access, but it's called Epistemic Justice in Mental Health Care. And there are a lot more contributions in there about different aspects of epistemic injustice and how it is lived and experienced by people with different diagnoses. It's all within mental health. But again, you know, dementia is represented, psycho-oncology is represented, personality disorders, so-called personality disorders are represented. And there is quite a lively discussion that emerges from, you know, the dialogue between these chapters. And the good thing about it, the thing that makes me proud of the book, is that we managed to put together, again, people with different expertise and different experiences. So there are philosophers, psychologists, clinicians, young people, people working in mental health organizations, people with lived experience, advocates, and so on. So I hope you have a look. And if you do, let us know what you think about it. Thank you so much for joining us today. Thanks again to Fiona and Martino for their wonderful presentations, and hope you enjoy the rest of Mental Health Awareness Week. Bye-bye.
Thank you, everyone. Bye.
Bye.